Okay, welcome everybody to the Rutgers Robert Wood Johnson Department of Medicine Grand Rounds. As a reminder, the video from today's session and almost all of our sessions is on our YouTube website, which you can access from the website rwjmsdom.org. On the website, we have all of our upcoming Grand Rounds, including next week's Grand Rounds, which is going to be given by Dr. Esther O. from the Johns Hopkins School of Medicine. She's going to be speaking on delirium. For today's session, the CME text code is 11980, and I will post that in the chat. During today's session, everyone's going to be muted, but we again encourage as much discussion and questions as possible. You can post your questions into the chat, and if you'd like to have that question or comment read aloud, I can do so. If you'd like to read it aloud or ask the question yourself, you can be unmuted. We're incredibly lucky to have Dr. Scott Ratzan here with us today. Dr. Ratzan has an MD from the University of Southern California, an MPA from Harvard Kennedy School of Public Policy, and an MA in Communication from Emerson College. He's currently a distinguished lecturer at the City University of New York School of Public Health and Health Policy, and he also holds adjunct professional appointments at Columbia University Mailman School of Public Health, Tufts University School of Medicine, and the University of St. Andrews School of Medicine. He's 3 decades of pioneering accomplishments in the US and globally in health communication, health literacy, and strategic diplomacy, and his achievements are too numerous to list, but I'll try to name a few of them. He's widely published in major journals and books, and is currently the founding editor-in-chief of the Journal of Health Communication International Perspectives. He's currently on the board of Global Health for the National Academies of Science, Engineering, and Medicine, the RAND Health Advisory Board, and the World Information Transfer, a United Nations accredited NGO. He's served as the co-chair of the United Nations Secretary General's Every Woman, Every Child Innovation Working Group, and on the CDC Board of Scientific Counselors. He's co-author, this is really cool, he's co-author of the term health literacy adopted by HHS and integrated into the Affordable Care Act, which he's going to, I'm sure, talk to us more about today. Most importantly and relevant today, he co-founded Convince, COVID-19 New Vaccine Information, Communication, and Engagement. And today's session will provide an overview of the challenges and the strategies to attain vaccine coverage at the individual, practice, and community levels. Thank you, Dr. Ratzan.
Well, thank you, Dr. Cohen, for the introduction and pretty comprehensive of work that I've been doing over the years. It's really a pleasure to be here today, although I'd hoped to be here in person, but I know you've switched to virtual ground rounds with the reality and that we faced with COVID. And I've been doing my best to try to update today on many of the activities that are ongoing and hopefully bring us up to speed with some potential areas that we can address in terms of what we now call vaccine literacy. So I'm going to begin sharing my screen, and hopefully that's okay. And if it's okay, I'm going to leave it in this mode. These Convince activities I have based at the CUNY School of Public Health, where I have my academic position, but also with others. And Convince also is a global effort that I'll mention later that I co-founded with Heidi Larson, who's one of the experts in vaccine confidence. We wrote an article years ago when this was all sort of launching well before COVID, which I'll get to later. Just as always, I have to do a little bit more on the disclosures. Much of this was listed in my biography that David, thank you for the comprehensive approach. But the important thing just at the bottom is I do have a grant now through CUNY from Merck, which is a national survey. We're trying to develop something called STRIVE, which is a scale and trust and intent for vaccination. That's vaccination in general. And I gave a lecture to Johnson & Johnson Medical Affairs a couple of months ago. And I'm quoted in today's New York Times also on that latest, Washington Post on the latest announcement that J&J made yesterday. But this is all information today from myself and hopefully the expertise that you can share and diffuse into your practice. First, of course, it's what we're all doing in terms of what makes people healthy. It's part of all of society. But as we know, more than ever over this last 5 years, I think heightened by the Trump administration and now continued on with misinformation that now is at a level that even the Surgeon General's first report that came out during this administration has shown that misinformation is front and center. And we've got to really work where our role is as physicians in this role of as leaders in society as the trusted source. But I've been engaged in a while, and as David mentioned, I was on the CDC Board of Scientific Counselors when Ebola hit, and we knew pretty well what we needed to do. And even then, we didn't have a single authoritative source on intermediaries and tools on what to do. You may recall in 1 week we had Governor Christie, Jindal, and Perry contradicting what was happening in both Washington with everything from, at that time, Tony Fauci and even the President of the United States and Secretary Burrell. So very often the United States gets confused, if I can say that, of who's in charge. It's not a lot of clarity. But we wrote this up in 2014, and then the Institute of Medicine later said we needed better communication. So it was pretty obvious when COVID hit, we needed to do the same thing. So I'm on the board at the National Academy in Global Health. We had a meeting in January. A couple of us, Larry Gostin and others there, Ruth Parker, wrote this article very quickly to say we need to do the same thing. We need evidence-based communication and a single source. This became the fifth top paper in 2020 for the academies. But we reran it in my Journal of Health Communication. I edited as a reprint in its entirety in 2021, because frankly, we still don't think we've had that leadership that we need from either the government in the United States or frankly, even the challenges that we face with the World Health Organization and our other institutions. I've been engaged with this vaccine communication for some time. In 2003, I worked in Washington at USAID, and we were trying to say at that point that we knew there was a challenge with vaccine safety, and that was then, of course, the Andrew Wakefield report and others that continue to promulgate unfortunate confusion and lies that have still been obviously disproven and with many publications. But since then, that has made it really a challenge with the vaccination issues. The vaccine confidence gap with the Lancet was the work that Heidi Larson did that I mentioned earlier. She's a medical anthropologist, originally in the US, now based in Europe, and just a couple of other articles. The one at the bottom with JAMA, I think Larry and I and Barry Bloom at Harvard School of Public Health wrote that we need to do more with all the levels of law, science, and communication. And still to this day, we unfortunately don't have the level that we think we need. So when this hit, we started to gather the same kind of information. We believed that the showstopper, as I think was, if I can say Tony Fauci's words, would be the vaccine. So we started to look at this. We published in Nature Medicine, in PLOS-ONE, a 19-country survey, in Harvard Business Review with Rebecca Weintraub on why businesses need to engage, checklists, and all sorts of issues, including the really looking at the hesitancy, and I'm trying to segment the population. Just quickly, in 2020, we found that 75% of Americans said at that point, before there were a vaccine, if a vaccine is proven safe and effective and is available, I will take it. The rest were not necessarily refusers or deniers, but there were about 8% or so that would say they definitely would never take it. But the 75% was a strong level that we thought would be able to get to and then be able to convince others beyond that. But while we had this data, the anti-vax folks just kept going. There was everything from a fake pandemic and a show called Plandemic that was on social media. The CDC wasn't helping matters, and frankly still hasn't in many ways. The anti-vaccine community, wasn't, share of voice was about 1/10, if that, logarithmically different than the anti-vax community was that much stronger than people such as ourselves, and the fear kept traveling. And as we said, we called for what we thought was an evidence base, but the government response was fumbled. And this is where I'll start to pivot into what we could be doing. One, this is far from over. We know that right now there are 3 vaccines where this was a slide I didn't update for emergency use authorization. The Pfizer vaccine has approval for adults, but the other ones are continuing to apply to move from emergency use authorization. And as we know, still many Americans have not received their doses. I just looked on the New York Times. That's one of the best active sites. And in New Jersey, we're not quite at 75%. I think first doses are only 64%. And there's certainly upside of what we need to do, not only in the state, but in the country. People still say they'll take the vaccine, but that's not happening. And we know of long COVID, and that's probably another discussion of the clinical issues and the reality of people at multiple ages. And we know less about the pediatric, but continue to have, unfortunately, more cases. So there'll be more complications that we need to look at and deal with. This was just a level of community transmission. I was trying to cut and paste the New Jersey ones in here, and I was unsuccessful. As I just mentioned, you can look at it well on the New York Times tracker, but the country is not doing well, if I can say that, with over 2,000 deaths a day, and cases are still growing. But again, what do we do together, which everybody can be healthy? I'll go back to the Institute of Medicine quote, and the question there is, how many legs does this elephant have? And as I pause for a second, without asking necessarily directly, I think you could see anything from 4 or 5. And this is how we live with this sort of constructive ambiguity on developing health in other areas. So we need to figure out ways to do this a little bit better. Whoops, I'm sorry, as I move this along. And this is a slide that I made, and you can see I'm not an artist, but I wanted to do this quickly some time ago when I gave a lecture in April, saying I thought we'd be able, even with all of our data, to get to 60% fairly well this summer. And we have got to that number. But getting to the herd immunity, which really is about 80%, even if we have the vaccine that is 90 to 95% effective, is going to be quite difficult. And that's really what we continue to see, is that especially as we have the states that have anti-mask and anti-vaccine sentiment growing, it's going to be almost impossible. So we have to figure out ways to really convert not only the wait and see people, but also these skeptics and refusers, to try to move them somehow into the normal, if I can call that from a normal curve, a normal population, but a population that follows good medical guidance. But as I said, we knew this for quite some time, and vaccine hesitancy, has been highlighted by the WHO as a threat that would be there. And unfortunately, what vaccine hesitancy, while this was said in August 2020, it's become something that's become mainstream. And when the New York Times said it was mainstream, I think Tom Frieden said it best. It's not really mainstream. It's a story. It's giving people an excuse. And because of that, we had issues of trying to focus on converting some of these wait and sees, but we didn't have vaccines available in places that people would go to, such as their physician's office or a clinic. And the problem was there. But even saying that, the president said, he didn't believe that there was vaccine hesitancy in May. The truth of the matter is more people are getting the vaccine. And so I've never believed there'd be a large percentage who wouldn't get it. Well, this is in May. And clearly, while it would be nice to believe that that would be the case, we know that people have not changed from being hesitant or being a refuser or not being interested in getting vaccinated. And now we have mandates and other issues, which we can talk about afterwards in the Q&A, if you like. So we started to continue to look for more and more data. What can we do to build the confidence? And even though we have all the survey data, and it's not just us, the Kaiser Family Foundation has a vaccine barometer that they've been tracking, Ipsos, poll after poll, you'll see week after week is showing that, people are not, willing to get full vaccination. So we were fortunate to get some funding from the Commonwealth Fund and CDC Foundation to figure this out from a qualitative approach. So we did a bunch of in-depth interviews, And, we found that, people are distrustful of, in many cases, the government. It does date back in some cases with the African-American population to Tuskegee, but that's not it alone. It also, the Latin or Latino or Latinx, depending on how you mention that, categorize that group, were very different, sometimes first generation or ones that had immigration status and other issues. So we were really looking at ways to help reframe this as a social movement. And I'm saying it's nice to have that as a goal, but it's very difficult. And we started to get more of this engagement we found now at the workplace. But just to give you the idea, and these are what we heard last year in 2020. And I think you'll probably, we would hear the same things today as we continue to do our studies. People still have concerns of safety. Some people just refuse. Some people more of the trust issue. And then finally, literacy, they don't understand. They think the vaccine can give them the virus or the disease, or that, vaccines you can use once you get infected. There's a lot of misunderstanding, if I could say that. We don't like to use the word illiterate, but you think we can build more literacy there. So we went to try to find out more again. And I worked with a group called Frisia that has patient intake software with electronic medical records and so forth. And this was 138,000 patients that we collected in March of this year. And basically, this is the New England Journal of Medicine chart, which is not so easy to read. But what it does show is that, of the respondents, of the people that were vaccinated, 40% at this point were vaccinated, but the remaining 60% really weren't just hesitant. They were either ready, neutral, or resistant. So we put that into another chart. And this database, I should say, the patients were from Ascension Healthcare. And Joe Ciccone is our chief medical lead there. And Eric Snyder is at Commonwealth Fund, and Hillary Hatch at Frisia. And when we broke this down, we said, look, these people are really ready. So in this population, 11% were resistant, but we were not reaching these 49% that were vaccine ready. Some, as you remember, in March, it was really difficult to get an appointment. So we just had to simplify that. And as people started to get appointments, in my case, I was able to get one in Trenton. My wife had to go to the Meadowlands, but you started to move people over. Then you had a receptive population, and the receptive people needed to hear, frankly, from many of you, they needed to hear from their primary care physician or from someone in the medical community who they would go to say, hey, it's time for you to get the vaccine, go register. And whether you go to a CVS, a Walgreens, or somewhere. And then there are these kind of neutral people. They won't go to the doctor necessarily unless they were sick, maybe waiting for their annual physical. And they, again, just needed to hear from the physician. So our major message here was unvaccinated medicines and primary care visits were most important. But many of you know that all primary care physicians didn't have vaccine. It wasn't being distributed that way. And frankly, if we even broke this down more, a lot of people didn't want to go to wait for a church, or they don't have the wherewithal to take a day off to go to the Meadowlands or wherever it might be. So we needed to simplify it. And that was what we were trying to tell the policy community. And just to, again, break that down, most people, as you see here, this was a couple months later now in June, wanted to go to their doctor's office. And that's what we were trying to move. That the retail pharmacy or drugstore tended to be actually the place of choice for some communities, at least in New York City, we're finding where a Hispanic population would like to go to a retail pharmacy, where an African-American population in the city would rather go to their physician's office or clinic. So you had even differences here. And this clinic or setup of my city or town was there. And few people wanted to go to stadiums or convention centers, but this is what the government was doing. But if we were able to move more to the left, we think we would have been able to get to a higher percentage of the population. And, the president was saying he was trying to get docs and ministers and priests to talk about it. And, the primary care physician in this poor illustration, if I can say that, this is part of a Rubicon MD CME, which you can, I'll reference at the end as well. But, these were some questions that were there. What do I do to my patients that's in and out of a long-term care facility? The pregnancy issues weren't clear yet. I mean, ACOG was out in front of had the recommendations before even some of the CDC and other national groups. So we needed to help coordinate that. And that's kind of what we were doing, and helping the interpretation of news reports, patient education, the dosing schedule, and the landscape. But the other thing is, as you recall, the ACIP, which is the Advisory Committee on Immunization Practices of the CDC, they were airing problems, if I could say that, when J&J had the pause with the vaccine and thrombocytopenia and some other issues. We also had miscommunication or miscommunication opportunities, which goes back to the piece that we've said at the beginning. Where were the either national or even state or even local leaders that were able to help people, whether they be in the catchment area of an institution, of a practice, or in the case of the United States. So we keep thinking that more news reports and valid social media would even be stronger in terms of helping out the vaccine issues. The patient education, this wait and see. And if we think, there were some states where people would get, well, right now in New York City, you get $100 if you get your kid vaccinated. Some places in Ohio, they had lotteries. Some places you'd get free breakfasts, Waffle Houses, and so forth. So many people thought they'd get more money if they waited. There was all this odd stuff we were finding. And the dosing schedule was a little confused. Should I get the one and done? With the J&J vaccine, and then you had an outbreak or a breakthrough infection with the Yankees. So you had a lot of different things that were confusing the public, and it is rapidly evolving. So we think it is still important to get the right information forward. And Larry Gostin and I wrote about some proven ways to do this in Stat News, and we believe still that mandates actually could be positive, and they could be used appropriately for people working in healthcare facilities, and notwithstanding, people now in large employers. So while we have mandates as, shall we say, the last straw, we still believe we need to ask people appropriately when the patient is in the practice. And again, this was the Commonwealth Fund research that helped support. Find out right away, are they interested? And if so, how fast can you get them into a vaccination and making a plan and getting it done, hopefully at the office then, or if not, scheduling it and administering it. But the know part, the listening to concerns and discussion, that's the part where we talk a little bit more about today. What do I do about that? And, some people are still asking, well, what if I've already had COVID? Do I still need to get a vaccine? And, this is the CDC information they're giving people. After recovering, people still should be vaccinated, and, 90 days after if they've had monoclonal antibodies or convalescent plasma. And the key message, though, is the strength and duration of the protection is more consistent with the vaccines, with the controlled trials, as we know, and the adverse event reporting that's out there, as well as some of their surveillance. And the vaccines are just as safe, for people who've had COVID as they are for others. So the durability communication is something that is really key. And frankly, a lot of people still are confused on it. So I excerpted this directly from the CDC to show that at least that latest medical guidance. And then even more specifically, is it right for me? And now we're reminding people it's for everyone 12 years and up. Pretty soon, it should be for 5 to 11-year-olds. All signals seem to be there. At least the Pfizer vaccine and Moderna is also filing. And it's for everyone who, even if you've had COVID, chronic disease, and even cancer. And this is the direct piece: pregnant, breastfeeding, or may become pregnant. So women of reproductive age and those who are even taking medication. Of course, the answer is to discuss with your physician, particularly, if there is a decision on which vaccine. And, there are some black boxes that have been added for the Janssen or the J&J vaccine for Guillain-Barré, as well as for women of reproductive age at some level. There's been some question on which one would be better, but that's up to obviously the discussion with the physician and the patient. And then, frankly, we also are saying that there are ways to just get some simple persuasion. And I have again wrote this in the Financial Times, because I think the financial community, I know the financial community and others want to get back and build back better and get some more predictability. We've been trying to say that both governments and employers need to support together both vaccine literacy and policies at the business level and government level to help get people vaccinated. And this woman is in Europe, as you see, and the no green pass, there are people arguing against her credentials. And I think that's the next piece that we're the next fight we're having already in the U.S. And we don't have a national credential, but we will have some. I know if you, at least in New Jersey, right, you can register on Docket and have on an app a QR code and a letter from the state. In New York, they have an Excelsior Pass, and other ones will develop. But these are motivational tools that hopefully will be done on a policy level. And thank David for the intro about the importance of vaccine literacy. Along with Ruth Parker at Emory, we wrote a new definition on vaccine literacy. I first started writing about this actually in the Harvard Business Review in 2011, because vaccine literacy, I think, is something that we need to aim at policymakers, politicians, and others who are helping not only fund health services, but also help make decisions for how kids should go to school, whether they're school-aged, whether, for example, the Commonwealth of Massachusetts last year had a mandatory even flu vaccination, seasonal flu, to go to college in Massachusetts. And similarly, vaccine literacy is something that when the system aligns with the necessary need for vaccines, people will align for it. And that's kind of the idea for a social norm that we're trying to build. And just for the sake of this group, not to go in from a lecture format per se, but a lot of this you all know and do. Individual knowledge needs clear, trustworthy, up-to-date evidence. How do we help people understand fact from fiction? And a lot of this is what you read on the internet, or Dr. Google is not a doctor at all. It's a search engine, and all the same sort of thing with Facebook, Instagram, or wherever people are getting their health information. How do we do more listening? And listening is probably more key than ever. Provide understandable, trustworthy, up-to-date answers. So where can people go for this? The risks and benefits of vaccination, successful education access and systems. So how do we have this still in the schools? Prudent policies that I've mentioned. And then I think finally that we have faith in the process, that we know that the FDA had the appropriate approval. And just to think back where we've been on COVID, we were worried that the FDA was going to rush it through during the Trump administration. And you may recall California and New York were putting their own regulatory authority in place to be able to follow what the FDA might said if they thought that Trump did this too fast with warp speed. So we've come a long way. And part of that is still the challenge of why we're here today, not at the level that we need for herd immunity. And, this is a characterization, right? The facts aren't working. And here it is. I'm sorry, Jeannie, your answer was correct, but Kevin shouted his incorrect answer over yours, so he gets the points. I mean, I think I can say with comfort that we don't have at least a president of the United States pushing unproven methods such as hydroxychloroquine or bleach, and having a bully pulpit to do that negatively. So hopefully the facts are moving forward, but it's easier said than done. So this is some more on the research that I mentioned earlier. These are reasons still to address with your patients. The top reasons that people should and do feel that we have found, even as you segment populations, it's really four things. One, to keep myself from sick and dying. They think that there's risk to themselves, whether it's of a new variant, whether it's a Delta or a Mu variant, or of some way of getting sick where they can either, one, miss work, or two, potentially go in a hospital, dying. And now you can even add probably a level there of cost, as those costs is going to be shifted from the system paying for everything to individuals. And you started to see that with Delta Airlines and others. Keep loved ones from getting sick and dying. We thought this one would be stronger. It is stronger in some communities where they have both younger children or older generations, or they're going to be visiting and so forth. So it's people that they care about. Oftentimes we find this on number 3, protecting my community, to be able to go to church, to be able to go to synagogue, or to be able to go to events that they like to now that they're reopening. And then finally, the seeing family and friends that they wouldn't be allowed if they didn't have the pass, or if they didn't have proof of vaccination. So these were the reasons that we thought would resonate. But still, number 1 across the board is it's not safe enough. It was emergency use authorization only. And our data showed that changing from EUA to full approval was only going to be 3 to 5%. And that's what we published and spoke about. Somehow Tony Fauci said he thought there'd be 20%, that they had some data that would change. And for better or worse, we haven't seen the 20% that Fauci predicted, and we have only seen a small increase when we went from emergency use authorization to full FDA approval on the Pfizer vaccine. Some people still have no concerns, and they just don't want to get vaccinated. And this is the ideologic issue that's become more of the unfortunate nature, as it's been politicized by politicians, some in parts of New Jersey, but other really parts of the country that we all know all too well. And still the speed. We have to remind people that mRNA, this didn't start in February. This was the platform that was being used for years. So now we'll just go to the final piece of different kind of language that the CDC and others are saying. Whether you're in pediatrics or family medicine or other, the idea of trying to be more presumptive, while we talk about shared decision making, and ultimately it is shared decision making, but the presumptive approach of what's necessary on that visit on that day, whether it's the annual physical or an example from a pediatric visit, your child needs TTAP, MMR, whichever they might be, they need it today, rather than participatory. Have you thought about it? These are the ones they're due. And it's seasonal flu. It's season for seasonal flu, if I could say that. So now is the time to get it, whether you're able to get it at the office or able to get it at a pharmacy or otherwise. And as part of this visit, we'll make sure all your vaccines are up to date. You still need to get your COVID vaccine. Do you have that today? And there's some articles that are in preprint that I've been reviewing that have been talking about bringing the booster and the seasonal flu and together. And it seems to be about, a 3 to 5% people that are more likely, I'm really gonna get my flu shot, I might as well get a booster. If you did them separately, it makes it a little different. So if this booster is approved, and there's only recommendation last Friday by the FDA for the 65 and over population, I think the CDC Advisory Council on Immunization Practice will be reviewing and making some other recommendations. And of course, you have the ability, based upon your own patients, if they meet other criteria, immunocompromised and others, you can talk about the need to get the COVID-19 vaccine for sure, if they haven't got that yet, or booster if they're eligible. So that's probably one of the take-home slides to think about here. There's also ways that, on motivational interviewing, I'm sure many of you have heard about this, again, from Health Promotion and Practice, particular ways to talk about vaccine hesitancy. If people are negative, ask them to share their concerns, listen, share some information, and reflect on that, provide the information of what's necessary, and hope to make that recommendation. I know that there has not been reimbursement for this extra time that it takes, and I know that there are some organizations that are trying to get that hopefully would help. But in the meantime, if you do have the time and do have the ability to do that, this is the appropriate approach. And furthermore, with that, preparing for the discussion with motivation, not moving from, as I used to call it, it's when I was in medical school, it was the white coat ethos. We don't all use white coats anymore. So how does the physician move from shared decision making to the guide and have the open discussion? How do we move from the traditional approach that people might have wrong information? They want to make good choices. We want to build a vaccine literacy and explain how vaccines have been important to rid smallpox from the planet, eradicate polio from the United States and most of the world, and to be able to remind people of the importance of vaccines. And then finally, while we are still, supporting patient autonomy and permission to refuse, we're really moving towards, yes, we respect them, but we want to listen to why and try to explain the importance. And then there's do's and don'ts on safety, and we can make some of these available if you like. But the safety concerns, are really, again, in the motivational shared decision ways that we want to make sure that you understand the safety issues that the patient is raising. Appreciate and understand that, some of the things they might have thought about, whether it was warp speed or the speed of this. And now that we're in, 2021, be able to ask follow-up questions of what they've heard recently, whether it's on the news, or if they're been reading something on their Facebook feed or whatever it might be on the sterility concerns or other issues. And then finally, try to start with the positive area of sharing the concerns you've heard from other patients, and as much as possible, if there are places still to point people towards, not just say go to the CDC site, but other sessions or other, perhaps even something that's on the Rutgers RWJ or other site, or maybe even we know some patient practices are actually having information right there that's available. And then other ways, other evidence-based pieces, the benefits of success. Look, we're able to go back to school, we're able to go back to work, and that's because over 70% of people are getting vaccinated. Focusing on the benefits of the success of that. And the same thing. I took this out from a year ago, because even then, the science was clear on mask wearing, hand washing, and social distancing, and we still need to reemphasize that. Even though people don't think that it's always mandatory, that this is not being solved by vaccines alone. Other discussion points, we don't expect people to take their public health measures just because it's good for them. So we talk about the whole aspect of understanding this, and this is why it's important for the long haul. And then, your personal politics, this is pretty clear. Again, this is sort of a cheat sheet from this Beaumont Foundation that's been put together, but I thought it was good to share where we were almost a year ago, to see where we are now. And then we've helped develop other resources. Rubicon MD is a CME provider, and have other resources that they made available. My understanding is free for all, irrespective of if you're part of this, with e-consults, resources, and patient materials that they're continuing to update. We helped give some early support for this with our testing that I mentioned earlier, and I think this is something that's hopefully positive. And then, just to end, I'm working in the public health scheme, and today, while I'm not here in New Jersey, actually I'm doing this in Washington. I'm speaking later today at Georgetown Law School, to also help get the legal folks and others to help support mandates, and help support the guidance and the requirements that we think are appropriate. Some of these ideas are also published in the journal I edit. Black Americans, this was a group out of Annenberg, Penn, that did this. This is an ongoing vaccineliteracy.com. We have a whole bibliography on that. The Hesitant, and The Decline in Trust, which is a group out of Johns Hopkins. We have Convinced that I mentioned, that just shows that we're all aimed in the middle at vaccine literacy and acceptance. And the four groups that we think are most important are healthcare workforce, all of you, media and technologies, community engagement, and private sector. And all of you go in and out of those areas. So if you're interested, you can, we'd be happy to talk and engage further. I mentioned earlier, businesses can make a difference. So again, I've been writing Financial Times at Harvard Business Review. We have resources of business partners to convince on this, myths and facts, and other resources that are there. And we've created a workplace challenge that companies are signing on to, Merck being one of them in New Jersey, that all throughout their company, they're listening to employees' needs. They're following the latest public health guidance. They're promoting vaccine literacy. They're encouraging vaccine confidence. They're advocating for accessible, equitable, and timely vaccination. And they're engaging and supporting community schools, faith-based organizations. Others are signing on to this around the world. Even small organizations can do that. And there's resources that the U.S. Council for International Business Foundation has put forward. We have podcasts and other pieces. I spoke to the Vaccine Competence Subcommittee at HHS with a lot of the ideas I shared today, and also here on MSNBC. And then just finally, are there some areas of what we can all do? And this is my penultimate slide, David. So can we engage with and anticipate and counter the disinformation? And I believe that physician is the most credible source. And how can we help continue to be not only for our local community, perhaps our patient population, but others? How much data do we need to support vaccine literacy? Can we keep doing this? Can we get our local communities and medical facilities and our health facilities to join this challenge? How do we advance our position as vaccination as a civic duty, and then community protection? So with that, as I said in the penultimate, that's me, my email. I'm happy to engage further in discussion here today. I know that there's lots of interest in multiple ways, but what is really the best way to address this? It's always it's not simple. It's easier said than done. And I know I put a lot out here today as part of the grand rounds, but I'm hopeful maybe with if there's any questions or discussion, we can further hone in to make vaccine literacy more of a reality and get us back to a point where you counter hesitance, you build confidence, and we get back to what our new normal will be. So, again, thank you for the opportunity here today.
Thank you so much, Dr. Ratzan. That was incredible and timely and insightful. We have a couple questions coming in, and I'm sure there's going to be a lot more. I guess, a lot of the question that I had, so much of what you talk about is COVID specific, but the themes are not. They really don't have that much to do with COVID. And this is a new pandemic, unlike anything we've seen before, at least on its scale, and especially with this vaccine. And you alluded to it a little bit earlier on. A lot of us are surprised about the hesitancy or the refusers. Did we miss something? Should we have seen this coming, 2 years ago, 3 years ago? And was there something that we should have done many years ago to, most of us weren't surprised that a pandemic like this happened, but maybe we should have anticipated such hesitancy. And what could we have done different? And what could we do next time?
Well, no, I mean, thanks, Dr. Cohen. I mean, really, this is really key that we have seen the vaccine hesitancy rise or the vaccine confidence wane. Frankly, since Andrew Wakefield, when he published that last century, if I say it like that, on the link with MMR and autism. And we continue to try to debunk that everywhere, from the Institute of Medicine publishing a series of papers and congressional hearings and all sorts of things. So that hit, and then it helped foster, and I can say the internet and Facebook has given oxygen to the anti-vaxxers, and this Saturday there was a whole full page, a 2-page spread in the Wall Street Journal looking at Facebook, how it continues to be sort of home to the anti-vaxxers, and I often call the cyber-gated communities that have connected people. And that has found its way into, before COVID, into measles outbreaks that we were seeing in different parts of the U.S., even pertussis outbreak in Pennsylvania, and others that we continue to see it lowering. So unfortunately, we had a perfect storm where we weren't prepared for a COVID vaccine. Operation Warp Speed didn't help it by calling it Warp Speed, calling it almost fictional, rushing it through. President Trump and the Trump administration, the way they were with it, didn't help. So again, you had this perfect storm. We have been trying to call for the vaccine literacy, and in progressive states, if I can say that, like New Jersey and Massachusetts have been more apt to to make it easier to get vaccines and to move to a higher level. So we might have been a little bit more, complacent in our regard, thinking that the population would follow medical advice. But we have continued to see this, and frankly, to get stickier, the deniers are getting stronger. So it used to maybe be 5%, 8%, 9%. It's been creeping up, and we've been doing these surveys globally. And we thought in that global survey I showed earlier here last year in Nature Medicine, the US was about 75% and France was lower. They had more people that were vaccine hesitant. But the way that the government had the response here in the United States, we are at a lower spot with vaccination than they are in France, a country that had the data would have showed would have been more difficult. We're lower here in the United States than we are compared to almost all of the countries in Europe. So the political response is quite important, and we need to normalize it to get it back in the schools. The US government has been calling for 70% seasonal flu vaccine by 2030, and we know we're far from that, even the last year before COVID. So I guess the short is we've known about it. As many of us have called for it, and unfortunately, we haven't responded with the response that we needed, despite what we knew.
All right, and thank you. Question about vaccine hesitance and vaccine refusers believing that there's vast underreporting of adverse events. So there's, and maybe you could also discuss very briefly the VAERS reporting system and the legitimacy of that, and the kind of you are on your own feeling that many have if you had an adverse event.
Sure. Well, I think I disclosed at the outset that I've done some recent stuff with Johnson & Johnson. I worked for 11 years as a vice president at J&J, both in Brussels and at headquarters there in New Brunswick, and was engaged, frankly, this is the first vaccine that J&J's brought to market ever. I mean, they purchased Crucell, which was the Dutch company that now has become Janssen and has been integrated in. But the regulatory process was much clearer for trials for medicines, as we know, phase 1, 2, 3, and then you have phase 4 post-marketing. And the vaccines don't have the same active post-marketing surveillance as we might for medicines. So you have this VAERS system, the vaccine adverse event reporting system, which is more of if I call it a passive system that an individual or physician can report. So we don't necessarily even know how valid that data is, because there's some belief that the myocarditis may be overreported by the anti-vaxxers in some children or young adults. So frankly, one thing that I actually called for, at the, I think it was the April meeting now of ACIP, the Advisory Committee on Immunization Practices at the CDC, was for more of an active surveillance system, that I think we need more of a phase 4 marketing. At that point, we were calling it, when we had the opportunity, when the J&J pause for 10 days was coming off, we could have put in active surveillance, as frankly, it's only about 1 in 8 people in the US have the J&J vaccine. The majority, overwhelming majority, have either the Pfizer BioNTech or the Moderna vaccine. So we have been lumping this VAERS piece to vaccines, and we start to talk about all 3 of them as if they're the same. And sometimes we even have this mix and match issue that's in there. So frankly, I don't think we have the best system with what VAERS is right now and how we're reviewing it. It's supposed to show signals, and it's also, if there are adverse events that are such as Guillain-Barré and others, that they do show up, there are ways that we can find those signals earlier and have some intervention. But it's not an active surveillance system that perhaps would be as good as it could be. I think the CDC, and I know others, have been articulating what I have to try to have a better system, but it is what it is. And I think we have to really hope to look at the docket that the companies put forward, that then the FDA reviews with both internal and external peer review as the best evidence that we have, and hopefully continue to have the CDC Advisory Committee and the FDA advisory committees continue to review as we move from emergency use authorization or looking at boosters or otherwise. So, I mean, that's sort of a short measure of it. The J&J press release that went out yesterday talking about their potential second booster is on a database that they're only reporting. They issued it by press release. I mean, I'm quoted in the Washington Post saying, it's promising of what they have, but it's not the same kind of peer review that we have normally. So I'm basically calling for more active surveillance. And I think the VAERS system, yes, we should all be aware of it, and it is helpful, but we also now have to have a sort of a second level of review and be critical and not not take that as the only adverse event and tracking system and surveillance that we have.
You mentioned earlier that the term warp speed, and that may have had some counterproductive effects from that terminology. And there's so much choice, politicizing, marketing, using choice of words in how things are received. And even, the term booster, in my mind, gives the concept that you need a boost because the original 2 or 1 wasn't good enough, rather than just the third shot of a series, just like we need multiple for MMR and many other vaccines.
David, I totally agree with you. And I think it's unfortunate that we came up with this booster so quickly. And the way our society is nowadays with the 24/7 reporting, as well as the fact it was, the Pfizer CEO is going out to mention we need a booster, or we will have a booster. The Moderna CEO is going out. These are non-physician led or the usual regulatory process where we have competent authorities that would call it, as you say, a third shot rather than a booster. There's also other reasons. Both J&J and Moderna took money from the federal government, so they have different in terms of their vaccine development versus Pfizer that's out there, putting in their annual report that they're making billions from this. And not without criticism, including yesterday at the United Nations of yes, we're thinking about the United States, but we have the whole world to vaccinate, and until everybody's vaccinated, we're all not safe. So if we were calling it a booster, you might not have the World Health Organization, Dr. Tedros saying, the U.S. should stop doing a booster before the rest of the world's vaccinated. It is part of a third dose regimen. And perhaps the J&J, while are using the term booster, maybe it should have been a 2-dose regimen. But this is conjecture and our discussion. It would be great for all of us to see the data. And maybe even be part of the design, because people ask me all the time, why is one 21 days versus 30 days? Well, that's how they put it forward in the negotiation they had with the FDA, both of those, Moderna and Pfizer in that too, and similarly with the J&J adenovirus vaccine.
Great. A question about the religious exemption, and which seems like a large loophole. And how that's going to be used and hopefully and potentially not abused.
Well, yeah, Larry Gostin, who's a professor at Georgetown Law School, we wrote something on this on measles years ago, actually, in the Washington Post, and Larry and I just wrote in Stat News that we think that we need to make these religious exemptions as difficult as possible. First of all, the mRNA vaccine, there's nothing in there that should have a religious exemption in either of those. And the religious exemptions are different in every state. And our belief is that there is enough legal ground for having these mandates, and that the religious exemption should not be used. And it looks like both the leaders in most religions, most in the United States, have been saying that they're the leaders of national organizations. So there is no grounds for the religious exemption, but it needs to be done on a local basis. And people might not want to hear from the National Association. They need to hear from their pastor, or priest, or rabbi, or whomever. So I think that's still another whole communication issue in the interfaith group to not only have on the COVID vaccine, but other vaccines.
Great. Couple more questions. Just going to read this. Really feel big factor is anti-vaccine false information out there, as you've alluded to. Any chance of official censure or removing of licenses of healthcare authorities who espouse such false information? Personally think no entity that is healthcare related should advertise on any anti-vax media.
Well, first of all, yes. Whoever asked the question, I think it's an excellent question. And I do know there's a couple states that have already started to look at revoking physician licenses who are anti-vax or promoting non-vaccination, whether it's in their practice or otherwise. You also have trouble with chiropractors in certain states that you might have seen in the national news. I think it's all up to all of us, a sort of last question of how to be both a health leader to also help health facilities, or anybody maybe in the medical field from the ethical side, to not advertise or to support those areas. It's much more difficult for people to say, I don't want to be part of Facebook, but yes, people will follow their dollars. And we need to help to work on that. The Wall Street Journal article this weekend on Facebook, and the fact that they're still promulgating this is really should be a wake-up call. And I know the federal government has been trying to figure out ways. Surgeon General's report confronting misinformation alludes to it, but it needs leadership at a local level. I would love to see, certainly something, whether it's in New Jersey or New York or others, that can help, really take a stand on it. So if anybody has that kind of interest, I'm happy to talk more, but also, personally, I think we need to support this as both physicians, and I call myself a public health physician, with communication. That's an excellent idea.
Great. I asked if I could, and Sharon, I don't know if you want to unmute yourself and ask yourself, but I asked for her permission to use her name because I think it drives the point home so much more. But our hospital, one of our hospital chaplains, Sharon Hindle, who made a comment in response to the question about religious exemptions, said that, her question is to ask the individual, did you get the flu vaccine? It's mandated. And if they did get the flu vaccine, then the request is denied. And the rationale is, if you got a vaccine, the flu vaccine, then it's not against your religion. And therefore there's no ground to stand on.
That's a great answer.
Wonderful. I don't know if anybody has any other questions before we wrap up here. I can wait another minute to see if any more questions come in the chat. But it was I have to say, there are a lot of comments coming through about what a wonderful talk this was. So much information to give us on how we can fight false information.
Well, thank you. I hope it was helpful. I know it was it's a wide landscape. We have a whole master's program. We try to teach some of this, and I've been doing a couple of these kind of grand rounds and town halls and so forth, but really appreciate the effort that all of you made. I think the chaplain's, Sharon's remarks are really prescient, and particularly as we enter flu season, to think about that. And hopefully all of you can integrate into your practice and discussion, both as leaders amongst friends and community, to help make a difference and help us get out of this. So let me congratulate you for all the work that you're doing, and David and Dr. Cohen and others at Rutgers there, of hosting this grand rounds and making this an important area to address. So thank you.
Have a great day.
Thank you.
See everybody next week.
Thanks.